the the main idea that I usually try to translate into the lectures is how we work in daily practice, understand how people works in our setting. I would say that Spain is not that much different from Romania in terms of resources that we have. So I think pretty much can understand most of the challenges that you have every day in the clinic. And I have tried to give you not the basic I assume most of all of you know, and give you a little bit more of that and some tips that maybe you can use tomorrow in your clinic. And if you are not able to apply that, maybe start to think about that and invest a little bit. Things have changed quite a bit since I graduated. It was 2006. And I remember how things started to be at that beginning. There was only one fluid that we give to dogs. It was either ringer lactate or sodium chloride. That was pretty much it. We didn't have many resources in terms of pain killers, so it was either morphine or nothing, or butorphanol sometimes. And things have changed quite a lot. And seeing your faces probably is something that you have experienced as well. So this is what I try to make on the lectures, make people think that veterinary has changed quite a bit and we can do better. So let's see if I'm able to translate to you that message today. I'm going to be a little bit short on time, so I'll do my best and not fly through the presentation. I will try to focus on the main points of the presentation that I think will help you more. But you will see there are many slides on these presentations that I might not stay quite a lot of, or will not invest many time on them. So these are real patients. These are patients that we manage in our ICU. I'm quite privileged, and I'm happy that I can work at the University of Barcelona. Honestly, we have a lot of resources, but as I said, I have been practicing in regular clinic, and where you don't have so many pumps, you don't have many monitors, and you have to do it with only your hands and your stethoscope. So one of the first slides that this talk, as you have seen, sorry that I didn't say anything, is all about fluids and fluid management, the perioperative management of them, pre and post stabilization, before and after the surgery. And one of the slides and one of the messages that I think is really important, because I have been always looking for the recipe and what really works and what not. And I got really frustrated over the years with that thinking. I found the answer on this paper, and honestly is something that is repeated on the literature, and when you read it, you realize, because that's real life, and every single patient is different. There are no recipes. So if you try to apply the same concepts to every single patient, no matter what, not considering his particular difference from the last one that you have, and this is something that vets do all the time, no? I had a hemoabdomen a few days ago, and this is what happened to that hemoabdomen. So the next one that I have, I'm going to apply the same that happened the last day. But it doesn't work on the next one that you have, because the one that you have now maybe has a dilated cardiomyopathy, maybe septic, maybe has some differences that the first one that you have did not have. So that's why you cannot apply and use always the same concepts with one patient to the next one. You have to always consider the patient that you have in front of you, no? And this is something that we all know, but we forget many times, no? And I'm just going to do what I am used to do, no? This is one of the cases that I want to present you. Is just an example, no? How things can change and how we need to interpret the deficiencies that they have in their cardiovascular system. So Bella was a boxer, and I think still is a boxer, 2 years old, who was hit by a car. She presented with a hemoabdomen, with multiple lacerations. There's a dog barking in the background, but this is the fast ultrasound that we did on admission. As you can see, there's free fluid here pointing out to the hemoabdomen, no? We'll work through that finding, no? She also had multiple lacerations and pulmonary contusions. This was another dog, Fosca, 6-year-old Labrador. She presented in hypovolemic shock, and we diagnosed on her septic abdomen. She went to surgery, as you can see here, and what we found was a perforated intestine. No, it was part of her bowel that was perforated by a foreign body. So something is different between these two patients. Both were in hypovolemic shock, but there is a big difference between them. One is losing fluid from one place and the other from the other one. No, this is what we are gonna talk about in this talk. No, and taking advantage of that, we'll try to think or point out what is the best fluid plan for these two different patients. We can do a common approach for both of them, but there are going to be some strategies that will be better for Bella, for the boxer, and there will be other strategies that will be better for the second one with a septic abdomen. So this is basically the summary of the lecture and the points that we are going to go through. Shock. We all know what is shock. This is a long, or if you want to call it long, it's not that long. It's just only 3 lines. But the definition of what is shock. But shock at the end is always the same. The oxygen is not getting to the cells. So if the cells don't get the oxygen, what happens? They die, no? And they start just to throw all the products that they have inside and inflame the system. So we need to ensure that oxygen gets to the cells. How we do that? We can give oxygen, but most of the times our first step is to give either fluids. Fluids can be crystalloids, colloids, can be blood products. No, that's what we have to do for them to recover the patient from the shock. Here you have different shocks. They behave in some way very similar, but they started from a different cause. No, but what they have in common is this path. No, either if your heart failing, you are in hypovolemic shock because you lost a lot of fluid, you have a problem not in the content, you have a problem in the distribution. No, like septic abdomen, for example, or sepsis is not a problem of how much fluid you have, it's how you move it through your system. Or maybe you have neurogenic shock, that we will talk about this more on the last lecture of today. What it happens at the end is that your mean arterial pressure goes down. When this happens, your baroreceptors take on and step on this to try to decrease the parasympathetic and increase your sympathetic tone. The only that you are trying to do is to make your body to work faster, to increase your heart rate, contractibility, and try to compensate. That would be the common path that they all share. This is the system summarized in 3 main components: the volemia, the vascular compartment, and the heart. All of them work at the same time, but the responsibility or the task that we have as a clinicians is to find out which one of these is not working well. Is the deficit in volume? Is the vascular compartment that is just not moving well? And by that, what I mean is, do we have like something distributive? Do we have sepsis? Do we have something that is making our vessels to not contract properly? Or is the heart that is failing? Because any of them or all of them can be failing at the same time in a patient. And yeah, it's all about how fluids move through compartments, or how they move through compartments. This is a capture of this paper that you will find in Vet Compendium. Has many years now. I think this paper, I read it in, well, it's here, 2009, but it gave me a good perspective of what is exactly happening, no, between the different compartments. So you have your intravascular compartment, your interstitial compartment, and your intracellular compartment. Is that easy? That you only have to think that when one of these compartments is failing, the intravascular, for example, the other ones are going to go and rescue the intravascular. So they are going to give water and components to try to make the intravascular go back again to his original shape. The problem is when we have the interstitial that is losing water, and then we have the intravascular failing because the interstitial is failing. That will make the difference, because that's when your fluids are going to make the difference in here. And you will see it through the next slides. One concept that we have known for the last maybe 8 years now is something that exists in the vessels. So these little hairs that you can see here are representing the endothelium of this vessel. And this is a concept that has made a revolution in how we use fluids in critical care. Why is that? Because for many years, what we were thinking, and it was all about the hydrostatic pressure here and the oncotic pressure in the vessel, and the difference with how many water, so hydrostatic pressure, or proteins, oncotic pressure, we have in the interstitial space. So we thought there was this difference between these two compartments that make the fluids move through one or the other. Now we know that proteins here don't matter. They doesn't matter very much. All that matters is this little slide of hairs that we have in the endothelium that is called the glycocalyx. Have you heard about this concept? Yes? So the glycocalyx is taking a lot of importance now because it seems that is the origin of, or is the one that is going to actually make the difference on how proteins move between this compartment and this compartment. And exactly what is the impact on all of this, on all of this theory? The impact is that we used to use a lot of synthetic colloids, for example, thinking that if we were able to increase the oncotic pressure here, we're gonna be able to move water into the intravascular compartment and get our patient better. Now we know that many diseases, at the very beginning, when you are inflamed by any cause, it could be a pancreatitis, it could be an accident because you are being hit by a car, it could be a pneumonia, it could be whatever. The endothelium is the main thing, or is one of the first things that is going to fall. So it's going to break down, and this barrier is not going to exist anymore. So does it really matter to give synthetic colloids to a patient that doesn't have this barrier? Honestly, where we are seeing now, and we are seeing this more maybe in human medicine than in veterinary medicine, because we're always like years back, not so much ahead than human medicine. What we are seeing is that we can actually harm more with synthetic colloids to these patients when we give them for a prolonged period of time. So now our options have been reduced quite a bit to crystalloids plus minus blood products. And this has been quite a bit of a revolution for us to understand that these little hairs of the endothelium are so important, and the cause or the consequence that when you give fluids to patients, most of them just swollen and swollen and swollen, and you don't know why. And you wonder, well, I'm giving synthetic colloids and I'm giving everything, but the patient keeps being very edematous. Does it happen to you? Have you seen this? Post-operative patients that just get floated like balloons after surgery, and doesn't matter how many fluids you give. So this is one of the reasons. And there is nothing we can do so far for this. We don't really know exactly how to restore this. There is only one study performed in mice that show that with plasma transfusions, we were able to restore this. But we'll see in the next future how can we this to get better. So if we go back to our boxer, so her main losses were the intravascular compartment. So we had a patient that was healthy, was not dehydrated, it was fine, but just suddenly lost a bunch of fluid from the intravascular compartment. So she was bleeding. So the others went to the rescue. This is something important for the fluid therapy that I will give you later. What are the options for this patient, the best ones that you can use? It's different for this one because on a septic abdomen, what you have is a bunch of loss from the interstitial space and as well from the intravascular compartment. So the strategy is going to be different. However, you have to remember that shocks and the main ones that I show you, they behave, or they can behave at the same time, 2, 3 of them. A same patient, what I'm trying to say is that the same patient can have features of different shocks on him. So to make our life a little bit more complicated, this is what exactly happens. And this is what happened to this poor dog. This dog was hit by a trolley. As you can see, he was pretty broken. Had like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 pumps. On top of that was mechanically ventilated. So there is a rule that as the more pumps you have, the less chances you have to survive. This is something that exists. It's a joke, sorry. Maybe in English doesn't make sense, but but this dog didn't make it. Anyway, what you have to see is what sort of impact will have on this dog to have 12 syringe pumps on him working at the same time. So the fluid therapy can be really tricky on a dog like this. So let's go to what is important, no? How hemodynamically stable is the patient? How you can assess the patient and start with only your hands, no? Physical exam. All of these are features of that the patient is in shock. Some of them or most of them you already know, but we usually forget to look at this jugular distension and the saphenous test that I will show you on this video. And one big mistake that I usually find on many vets is that they, at this point in time, consider the skin test as a sign of perfusion. So that's a hydration parameter, but it's not a perfusion parameter. When you are looking for the perfusion, you are looking at the slide, the first one, that it was the heart, the volemia, and the vascular. So you are just looking at the vascular and the volemia. That's it. You are not looking for hydration at this point in time. So this is what exactly you have to look for. And this is something that is adapted from human medicine, but in my experience can help you quite a bit when you don't have many resources. In human medicine, it's called the leg passive raising. So the only they do with us is to put our legs up and see if with that movement we can make like a physiological fluid bolus, is how they call it in medicine. And this helps doctors to discern or to differentiate if the patient is fluid responsive or not. We use it in vet medicine to see if the volume status of the patient is correct or not, as you will see on this video. So let's stop here for a second. So what you have here is a patient in lateral recumbency. It was just like this. This is the saphenous vein. Okay, as you can see here, it's decently ingurgitated, no? So now what I'm going to do is just to move it up and then put it back again, okay?
Levanta.
So this is what I'm doing. And as you can see, the higher I go,
Perfecto. Vuelvo para abajo.
Disappears. And then when I go back again, it takes a few minutes or seconds to get back to his original shape. I'll show you again, because the first time that you watch it, it's always different.
Levanta.
So the saphenous disappears as you go up.
Perfecto. Vuelvo para abajo.
And then when you move back down, it will take 50 seconds to come back. So what is the trick in here? So if the patient is hypovolemic, you probably will not even see the saphenous vein at the very beginning. So you will have
Levanta.
be certain that the patient is hypovolemic. You don't need to do the test. But if you watch the saphenous vein there,
Vuelvo para abajo.
and then you put it up and then it disappears, probably this patient is still hypovolemic. And it's a if it goes up and the saphenous stays and you move down and it still stays, then the patient is probably not hypovolemic. Probably has
Levanta.
Okay, and this is something very easy to do. You can also look at the jugular and see how they.
Perfecto. Vuelvo para abajo.
There are many things that you can do, and we have ultrasound to look for most things. But this is something that will do the physical exam and give you another piece of information. At the very end, is not only based or everything based on just one test. It's the sum of all of them what will give you the answer on how the patient is looking. And it happens to you and it happens to me as well. Sometimes you see just things that don't make sense in a patient. And it's just like, well, this is looking hypovolemic, but at the same time, it's looking like distributive. I don't really know. I'm just going to try with this, with a fluid bolus, and see how it works. This is humans. This happens to all of us. So you have to just gather as much information as you have. This is a diagram that may help you to localize how shocky the patient can be. It really helps me, but it depends on every one of you. So here you have what is a patient in compensated shock, and then the different stages. No, early decompensated, and this is when you have to think about euthanasia because it's too late. No, with late decompensated shock. So what makes the difference on physical exam? It's really simple. When a patient is in compensated shock, pretty much everything looks normal, except that the patient is tachycardic. But for the rest, it looks pretty normal. When he starts to be in early decompensated shock, things are getting worse, and his mental status, that many times we just don't pay too much attention because animals cannot talk to us, is a little bit depressed. So it's this kind of patient that is not wiggling the tail, is not looking at you, it's just like not himself. So this would be depressed, and then we start to see hypotension plus the tachycardia. And when we get to this point, it means that the losses of this patient are quite marked. It could be 35 to 50%, and this patient is in clearly hypovolemic shock. No, it's quite shocking. This is fantastic, but they make our colleagues from the United States made the system that can help us to differentiate the patient that is in shock with just only two parameters, that is the heart rate and the systolic arterial pressure. This is something that is useful, but it's only for dogs. Why? Because cats are special. Cats are just different, and they are not going to behave like a dog. So don't try to apply this to a cat, because you will always see that your cat is never in shock when the cat is actually in shock. So why is that reason? So what they saw on these patients was that the heart rate divided by the systolic arterial pressure when this was performed, always a result over 1 meant that the patient had some kind of shock in himself. And this is something that, well, if you think about it for a second, is obvious. No, if the heart rate is 200 and your systolic is 80, obviously it's going to be more than 1. No, it's quite easy, that math. But this is really helpful when your heart rate is between 140 and maybe your systolic is 100. Then the result that you will have is 1.4, and that patient maybe with 140 of heart rate and systolic of 100 maybe will not look that bad. And you might think at that time, well, maybe this patient is not in shock, I don't need to treat anything. So this test is actually, the shock index is quite useful for those kind of patients that might not look that bad, but when you put the results in the formula, then you get a result that is somehow intriguing, no? That can give you some idea that something is not right, and maybe you are moving in this area for that patient, no? So that's the usefulness of this test, no? Can we use something else to validate these patients after we have used the physical exam? Yes, the ultrasound is something that it works really well. I don't know how familiar you are with. Do you have ultrasound? Do you use it, the ultrasound on emergencies? Yeah, so then you have an idea how helpful this can be. I didn't have time to focus on what is the thoracic fast or the E-fast, but basically what we do on these exams is, the first one is to look for free fluid. If there is free fluid on this patient, something is wrong, so we just take a sample of that. Another thing that we do is to take a look on how the heart is pumping. I mean, how much fluid is in those cameras, and at the same time, how is contracting that heart. You will see it on the third lecture, that one. And then something new that we are applying is to measure the caudal vena cava. For years, what we have been doing is just to take a look and see if it was more compressible or less. Now what we are doing is to measure the caudal vena cava to know if the patient will be more fluid responsive or less. Why do we have so many tools to assess the volume status? The fact is that none of this measure is very sensitive, so we have to add more and more and more information. Quick blood test that you can use. What we are using the most is the lactate. Do you have this machine as well? Do you work with it? It's worth it to invest. It's not expensive. Today in euros, maybe is around 100 euros the machine, and the strips are not so bad, maybe €1 or something like that. So it's something that will give you a lot of information. And the lactate is the byproduct of the cell when the oxygen is not getting there. So if the lactate is high, most of the time is that your patient is suffering somehow some type of shock. So this is something that we add to the physical exam. And if it's high, then probably your patient is suffering some sort of shock. Other values that we are using, the base excess in this study, for example, they found that the base excess, if it was less than 7.3, the patient will die. If it was less than 6, transfusion will be required. So these are other things, but it depends if you have blood gas machine for this or not. And the investment is higher for this. For the lactate measurement is actually quite affordable, I would say. Okay, all this information is helpful, but how do I integrate everything in a patient like this one, like this German Shepherd, no? Pumps, ultrasound, monitor, urine production, blah, 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 no? So you need a plan, and you need to go step by step, because otherwise you will just mess up with all the information on these animals. So what we do, this is my recipe for for me and for everybody that I teach at the universities. This is what I try to, the message that it was transmitted to me during my residency, and the one that I try to transmit to the residents and interns. Try to go through these steps and do your best. Maybe you will not be able to do all of them, but as many as you have, the more information you will have. So when you start with your physical exam, look for the volume status of the patient to see how stable it is. After that, look for arrhythmias. Try to get a blood pressure on the animal. It doesn't need to be invasive, but probably you have a machine to do a non-invasive blood pressure measurement, and with that, maybe you can apply the shock index, and have an idea. Do a pulse oximetry on the patient if the patient allows you to do it. If the patient is trying to bite you, there is no point on doing that, no? Or sometimes if the patient is really shocky or hypoperfuse, you will not get a reading of any of these. So nothing happens. I mean, just keep moving. If you don't get the value that you want, it's not the end of the world. Just keep moving and give the treatment that you consider at that time, because once the patient gets better is when you will start to see a response and values on the machine. Pass the ultrasound on the thorax and on the abdomen and take a look if something is happening, but don't invest more than 5 minutes doing this. This is another big mistake, and I have seen, and probably you have seen, patients dying during an ultrasound. No, sometimes we just push too much on the GI tract. Sometimes we just move them around, and then a vagal event happens and game over. No. So this is something that is called fast because of something. 1 minute, 2 minutes, just look for fluid. You are not, or I'm not a radiologist. Maybe one of you or people in here has more experience than me on this, but seriously, don't spend too much time. And then get your blood sample and just look for these parameters. PCB, total solids, glucose, electrolytes, lactate, the minimum that you can have to get an idea of what is really wrong on this patient. Okay, now what we do once we have found that the patient is hypovolemic. So the main mistake that I was saying on the first slide, as the people usually ignore the volume status and just focus on hydration plan. So they just step by this, or they just jump on this first part of the treatment plan and just focus on this. And I have seen this so many times that I now think it's worth it to put it on the lectures. If the patient comes into the clinic and is shocky, the fluid plan that you are planning for him cannot be twice maintenance, 3 times maintenance. First of all, what you have to do is to recover the perfusion of this patient, and we will see how to do that. Once you get the patient in a stable way, then all right, then is the time to put it on 12% dehydration, 10% dehydration, whatever you want. But don't make the mistake to just let them on a cage at 5% dehydration and forget them for the next 4 hours. We are all busy. Probably we have to go back and pass some consults and talk to clients, and then we forget. But if you jump and forget this first part, probably the patient will die. What fluid plan should I use? There are so many that you can go crazy with this. So adapt plan to every patient, okay? Knowing the main concepts that we will talk about. So in compensated shock, we were saying that the losses are 10 to 25 and early 25 to 35. And when the patient is getting to us very late, is almost 50% of the volume, no? You will see that the patients that are not so bad, they respond quickly to one fluid bolus of 10 to 20 mils per kilo. So that can give you an idea as well, the response of the patient that is having to your fluid therapy, what's happening on that animal. So it was not that bad. When you have a patient on this, maybe will not have so much response to fluid therapy. And then when you have one like this one, probably there will not be very much response to fluid therapy. And this is something that was bothering me for many years. And when I read this on human medicine, I said, okay, well, I'm not doing that bad then. This is the Frank-Starling law. As you can see here, this would be a normal patient. This is cardiac preload, and this is the stroke volume. So what this diagram is trying to explain is, as long as you give fluids to a patient, as long as you increase the cardiac preload, your stroke volume has to be better. This is in normal conditions, but when you are sick, this doesn't happen, and your heart is not able to pump all the fluid that you are giving. And That was a good thing to read because many patients in human medicine, up to 50% of them, don't respond to fluids. And a good response, something that we need to integrate in our minds as a good response to fluid, is at least a 50% improve on parameters. So if your heart rate was 200 and now is 170, you are doing something good. So keep moving on that track because you are doing good for that patient. Don't give up. But if you don't get the response that you were expecting, it's okay. Probably this patient will have more problems than just volume. Maybe we'll need vasopressors at some point, or maybe we'll need other type of fluids. Goals that should I use during resuscitation? This is what you have to look during your resuscitation, no? During the perfusion part of the of the stabilization of your patient. Try to normalize or just get them better. To get normal takes hours. So don't just focus on get that 200 down to 100. Maybe we'll get on that patient and you are lucky, but sometimes it just takes a little bit of time. Maybe it will take you an hour and a half to get that patient stable. But as long as you are seeing a response, as long as you are seeing that that patient is getting better and the pressure is not falling down again and the mental status is getting better, you are doing something very positive for that animal. Get them warm. We know that, but we forget that. It's as important in cats as in dogs. Hypothermia is a problem in dogs as well, and especially for dogs like that boxer with a hemoabdomen. Hypothermia after a traumatic event, what it's going to do is just to get the coagulation system to work less properly as it should, so you will have more problems to get that patient stable. So warm them. How much? 37, 37.12 should be enough for the body to to be working well. Normalize or try to get your lactate better. The lactate is something that we use a lot in septics, for example, and something that we know that if we get it in a half for the first 6 hours, the patient has more chances to survive. It's what is called the lactate or lactate clearance. So if you can track on that, or for example with GDVs, no, with dogs with gastric dilation volvulus, then that's something that it will give you a piece of information. Get the urinary output over zero 0.5 mils per kilo per hour. Get your mean arterial pressure over 60. You don't need always a mean arterial pressure of 100 or 80, but as long as you get 60, things are not going so bad because that's enough for your brain, your heart, your kidneys to work. It's different when you have a patient with a spinal trauma or traumatic brain injury because the spine and the brain suffer way more. So on those patients, you have to be insistent and try to get the mean arterial pressure over 80 or around 80. In those patients, then you will be doing fine. The important or the tricky part is what do you do when your when your patient has a hemoabdomen, pulmonary contusions, and traumatic brain injury at the same time. Then you are in trouble, or the patient is in trouble, but you as well, because then is when you have to decide what is going to kill first this patient: the hemoabdomen, the contusions, or the hit in his head. No, then is when you have to choose. And I don't have the right answer. I have asked this to medicine doctors as well, and it's funny because they have no idea either. So that puts you in a situation that is like, well, hopefully I don't get into trouble and never happens this to me because neither the doctors know what to do. But my option has been and my advice has been always to treat what is going to kill you first. So if the hemoabdomen is killing you and you're bleeding like a pig, then okay, man, just keep working on the hemoabdomen. We will care about your brain later on. And that's an advantage for dogs and cats in our profession. They don't need to do maths. They don't need to do anything important in their lives more than just to be with the owner, or that's what we think. So take that chance or go in that direction if you find yourself in that situation, because many times it's not that easy to choose. What about the urinary output? This is something that it was fun for me to read that, because who of us is gonna place a urinary catheter during an emergency and measure their urinary output? Seriously, that's something that doesn't happen. No, it's impossible. So, well, it's possible, but we are not going to invest our time on that. This tool, if you have ultrasound, is really helpful, and it will save you a lot of time, a lot of stress, and it's just to measure the length, the width, and the height of the urinary bladder. And with those measures in centimeters, if you put this information on this equation, then you will have how many milliliters of urine are in that bladder. And honestly, that's helpful for emergencies and for patients in the intensive care unit. That really works well. And you can have an idea with a 10% of difference on how many mils of urine are in the bladder. How to manage the patient with overbleeding, the patient like the boxer, no, that is just bleeding here. So these are the fluids that will help you the most. You can use isotonic crystalloids. You can use Ringer lactate. You can use Harman solution. Whatever you have in here. I'm not familiar with the solutions you might have here, but they will be pretty similar to the ones that we have. No, Plasmalide, Harman's. Do you work with B Brown in here as well? So isofundin is another good one that they have. So you can use these solutions, but be careful, because if you dilute them too much with crystalloids, these patients will start to have problems with coagulation. Especially, and I'm talking about the ones that are really shocky and are bleeding, like the one in the first slide. Why that happens? That would be another lecture about traumatic coagulopathy. But basically, when you suffer a trauma, your coagulation system gets really upset. And what happens is that your factors start to be consumed, and your fibrinolytic system as well starts to work a lot. So when you give a lot of crystalloids to those patients, what happens is you dilute them too much. And we have seen that that's a problem for these patients. So what we usually do is to start with a bolus of 10 over 10 minutes, 10 ml per kilo over 10 minutes, and see the response. If there is a good response and the patient stops bleeding, or we just see that the heart rate gets better, the pressure gets better, we don't push them more than that. We just stop there. If the patient is asking for more fluids because the heart rate is not getting better, the pressure is not getting better, then we just go up with another 10 ml per kilo. If he needs more, another 10 ml per kilo. But we stop at the 30 ml per kilo with the isotonic crystalloids. And then our next strategy is the hypertonic saline plus menosynthetic colloids. Synthetic colloids on these kind of patients would be the only scenario where they are widely accepted as a good strategy to resuscitate patients. So when I was talking about the endothelial glycocalyx, and I was talking about all of these problems that we had with the proteins, that was meant to not use synthetic colloids for a long period of time of infusion. But when you have patients like these ones that are dying in front of you, these are the only accepted use that they have to try to restore the intravascular compartment. And how we use it is we mix hypertonic saline with a bolus of synthetic colloids, both at the same time. Okay, trying to get this patient better. And if you ask me, can I just use this one instead of this one? Of course you can. I really like hypertonic saline in these solutions, but no more than 2 bolus plus the synthetic colloid. Okay? Why I don't like more than that? Because then your dog or cat will start to be really hypernatremic, and then you will have problems with that patient. If he's not responding to more than 2 bolus, means that your strategy needs to be changed. And the next step is to give blood products. The thing is that in veterinary medicine, we have blood banks and we can use them, but we have a client, if he has to accept a budget, we need to discuss finances, blah, 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 and the patient at the same time is dying in front of you. So these are strategies, the isotonics or the hypertonic saline with the colloids, that will save you some time, can help the patient, and then let you decide if you really have to give to this patient blood products or not. Okay? What if the patient with bleeding also has pulmonary contusions, no? And then you don't want to push too much on fluids, because that boxer, for example, if I flood her with too many fluids, then the lungs will start to fail. And if they start to fail, then I will have another problem like the one with 12 pumps. So I don't want to get to that point, right? Oopale. So there are no specific rules. That's the intriguing part of this specialty, that you have to do your best with whatever you have, no? So my only advice that I can give you here is resuscitate until you get a decent hemodynamic response. I mean by that, your heart rate gets in something acceptable, 120, something like that, or even better, or your blood pressure, your mean arterial pressure is over 60. If you get the patient just right there, when you get there, slow down with your fluids and just try to get the patient on maintenance or the highest 1.5 maintenance, okay, to get that patient cruise and the bleeding make it stop. Might not work or might work for just a little while, but if it doesn't work and the patient does not respond to this, maybe what you have to do is to go with transfusion or a new concept that we are using now, and it's not that new, it's something that we knew, but we did not apply it very much, that it was get the patient into surgery and stop the bleeding that that patient is suffering. Okay, so those are kind of the steps that you have to do. But the intriguing part of this with the pulmonary contusions is to know when to slow down with your fluids. And as I said, the only thing that you can do is to start to go down on your fluid therapy as soon as the patient gets stable and not keep him on 3 times the maintenance rate for 6 hours. Then you will get into trouble with this animal. When we decide to transfuse these animals, there are triggers. So there are no clear transfusion triggers. You can see patients with 40% of PCV or hematocrit that are just pale, bleeding, and they need blood transfusion. And then you can see patients with 18% of PCV that just don't need a transfusion, right? The decision this is based on clinical signs of the patient. And if the patient is asking you for blood, you will see easily that he does not get stable with your crystalloids or your synthetic colloids. So that's the point when you will have to do it. As a rule of thumb, less than 20% is usually a trigger to transfuse those animals. As another rule, and you know this, but it's always good to remind, when your solids, your proteins in blood are less than 5.5 after a traumatic event, probably that patient has bled. It doesn't matter if the PCV is 35 or is 40 on that patient. If that patient with 35% of PCV and solids of 3.2 is not getting stable, probably he will need a transfusion at some point because the bleeding has not been controlled. Indications for plasma transfusion. We'll see this as well on the third lecture, but as you will see here, hypoalbuminemia is the big one, and I would like to take you this with some caution. Okay, when the albumin goes down, okay, something is happening and something needs to happen. We need to increase that value on the patient, but only the fact that the number is low doesn't mean that you need to transfuse that patient. So you have to put it together with the clinical signs that the patient have. If the patient has edemas or is hypotensive, then it makes sense to give plasma transfusion. But if not, then there is no reason. Another good reason would be the patient that has an altered profile of coagulation, your PT, your PTT are really up in the scale, and the patient as well has bleeding tendencies. We have been transfusing too much plasma to patients that didn't really need it, and sometimes we will see that the coagulation just goes a little bit high because there is inflammation in the system, but not because the patient is bleeding. And sometimes when we transfuse this plasma to patients with PT and PTT that are prolonged, actually when you look on other tests, these patients are hypercoagulable, so they don't really need it. So if you put all these things together, and that's how we practice, if the hypoalbuminemia is making this patient to be or to look like a balloon or has hypotension that need vasopressors, then we give plasma. If not, then we just cut on the fluids and try to feed them. We place a nasogastric tube and we just give them food if they want to eat. If they don't want to eat but they are not having problems, then we just stay calm and give the fluids that they need in terms of crystalloids. That's it. We don't give synthetic colloids or do albumin transfusions or anything like that. When do we use the albumin transfusion? Only when we have patients that cannot afford a plasma transfusion because it's so big. These days we have been treating a Bernese mountain dog. He was 50 kilos. He was with an albumin of 1.2 and he needed vasopressors. He was in real trouble, and plasma transfusion for that dog was up to 1,000 euros, and one bottle of albumin was about 200 euros. So if you put that on a balance, on a scale, and you explain that to the owner, most of them will choose the 200 euros, knowing that the patient will not be or will not get transfused with albumin anymore in his life because he will develop antibodies. But those would be the cases when we actually use it. And we use it for cats and for dogs, if you have that question. So we have been using it. I rarely had problems with albumin transfusion in my life. That has not been a real problem. I have seen maybe 2 reactions, and they were very mild. But we all know that can be more reactions at least in the literature that have been described. Vasopressors in patients with bleeding, actually no. As long as you maintain a mean arterial pressure of 60, you can use it. And this is something that I want to mention because this has changed as well for dogs and cats. This is European guidelines for humans, but this is something that we are applying as well in veterinary patients. So use it. Don't be afraid to keep the mean arterial pressure up to 65. Okay, in something that will keep your patient stable, at least to make it to the next step. That probably is to go to surgery. How to manage the patient with third space losses, the one with a septic abdomen. So these patients are different in terms of what sort of fluids we are going to need. These ones really need to be pushed with isotonic crystalloids. These ones are the ones that when you put here the fluids, these are going to go into the interstitium and are going to fill this space that is causing the trouble. So you need to fill these to get this a little bit better. Okay, so this is going to take you some steps. These patients are especially inflamed, and the glycocalyx is really bad on these ones. So you are probably going to need at some point plasma to be transfused to these animals if the total solids go really low, or if they depend on vasopressors. Most of these patients have gastrointestinal problems, and the GI tract, as you know, is full of bacteria. So septic abdomens, patients with parvovirus. Pancreatitis is not especially septic in itself, but it can have this as a complication as well. So these are the kind of patients that I'm talking about on this slide. Okay, these are the ones that probably you will need all these strategies. The patient is hypo or hypernatremic when he gets into the emergency department. How do we resuscitate these animals? This is another question that sometimes we have, no? And the answer is really easy. So you only have to use a fluid that has sodium that is similar to the patient, plus minus 10 milliequivalents with whatever the patient has in his bloodstream. So that's pretty easy. When the patient has a sodium of around 165, something like that, that's most of the time is like that. When the sodium is lower than 130, we have Ringer lactate, so we can use that. But what happens when the patient has a sodium over 170? That's when we get into trouble, and we have to get into the clinic kitchen and do our own fluids, no? And this is something very similar to do. Honestly, it's something easy, not similar. It's easy to do, but most people don't know that when you took hypertonic saline 7.5, 1 milliliter of this solution is 1 milliequivalent of sodium. So you can add as much sodium as you want to any of these solutions and make the one that you want for your patient. If your patient is in shock and is in 180 and you want to resuscitate that animal, you only have to come here and think, okay, how much sodium do I have in a Ringer lactate solution? 134 approximately. So I will need to put about 20 or 40 milliliters of hypertonic saline to make a solution that I can use to resuscitate this patient. How do I manage patients with marked metabolic alkalosis? This will work when you have a blood gas machine. If you don't have it, but you can measure electrolytes, if the potassium is really low, then probably the patient has metabolic alkalosis. So this is easy to manage because the only thing you have to do is to give potassium to these animals. And here on the next slide, you will see how to supplement the potassium on patients. Probably you are not used to this table. You will probably be more used to the table with 20 milliequivalents if the patient has a potassium of 3.5 to 5.5, blah, blah, blah. This is more accurate for patients that are really sick and are really in trouble. So this is what we do. When the patient has a potassium less than 3, we put them on a CRI for 4 hours and then check the potassium after 4 hours. This can give you actually a much improved response on these patients and a better response to the metabolic alkalosis that they have. Just to finish, how to approach septic patients. This is a concept that is being applied in human medicine and now is translated to our medicine. And there are 4 phases that we'll see on the next slide. And basically the problem that we have with septic patients is that we give them so much fluids because they don't respond as other patients to the volume resuscitation. If you remember the Frank Starling diagram that I put on you, they are not on this part of the diagram. They are just on the low side. They don't have good stroke volume, no matter how much fluids you give to them. So that's a problem because we see patients that are demanding us for more fluids, are asking more and more fluids, but what happens to them is that the glycocalyx is a mess. The heart is not working well. So you just see them getting more and more edematous and more inflated, like this guy here. So the problem that we have is that the more fluids we give, the more edema we create. And if you are seeing a patient with edema outside, I mean, when you look at that shepherd and he's puffy like this, the skin is really jiggly, that is just a marker of how bad he is inside. So imagine how his heart is going to be, his GI tract is going to be, everything is going to be really swollen. And that's going to be a problem in terms of this concept that we will see on the management of abdominal patients, intra-abdominal pressure. That will be something that will make an impact. So now that we know that septic patients do not respond well to fluids and we have a very high risk of fluid overload, what has been created is this fantastic acronym that is really pretty with a rose that remembers us how to resuscitate these patients. And is, well, is exactly what we have been talking so far, is resuscitation phase, optimization phase, stabilization, and evacuation. So you have to keep clear in your mind these 4 phases, and then you will be able to see how your patient improves and in which part of the rows he is sitting right now. No? How we adjust fluids during the resuscitation on these patients to avoid fluid overload. I was saying, well, with your physical exam, you have enough. If you have more resources, what is being doing today is to use other parameters that are called dynamic markers. And these are the pulse pressure variation and the systolic pressure variation. To do this, you have or you need to have a setting with many resources to place an arterial catheter, to have invasive monitoring, and to measure the pressure on this patient. No? But this is something that it works better than our physical exam. And as you can see here, is something very simple. If you have your monitor like this one in here with a measurement of the blood pressure, what we are doing is just to measure the difference of the systolic pressure during the respiratory cycle. And that has been proved to be a good marker of fluid responsiveness in patients. Can any of you do this in here? Do you do anesthesia monitoring like this? Then don't worry about that. It's another thing that you can use in your clinic, but it's not something that you need to do specifically. I mean, it's something more to do. The optimization phase, or how to avoid fluid overload on these patients, in terms of what we can do, and something that I always remark is this. Wait, please, your patient after your fluid plan has been applied. Wait him. Because over the first 24 hours, 48 hours the most, if you want, you are going to see how fluid is retained on that animal. If he gained around 10% of weight over those hours, your hydration plan is fine. You don't need to push it more. And if you get into the mistake of pushing and pushing and pushing, just thinking, or not waiting the patient, just thinking that you are going to get the patient better, is when you will get the fluid overload on these ones. So this is something that you need to keep in mind. Okay, 10% is your hydration plan was fantastic. You don't need to do it or push it much more than that. Then we get to the stabilization phase, or the final phase that will be achieved over days, is when your patient is really not shocky, but is just like in a stable plane. But for example, he's losing a bunch of fluid through diarrhea, or maybe in one of the drains that you place on that one. On these kind of patients, the only you have to do is to match what is getting in and what is getting out. Okay, consider the urinary output, consider the GI losses, consider if you have a drain in place, and just add that to the maintenance volume. Don't make the mistake to fall in the perpetual 6% dehydration plan, because probably you are going to you're going to give many fluids that this patient doesn't need. The last phase is the evacuation, is when the patient is actually needing help to do diuresis, when he got so much fluids that now he cannot get rid of them because the kidneys, for example, are not working. And this is the evacuation phase where we help with some furosemide. And this happens to all of us. This Bernese mountain that I was saying to all of you before, we have to give some furosemide because that dog got too many fluids. So what we do on these animals is to use little dose of furosemide, like 0.5 milligrams per kilo, just to try to them to get rid of some fluid. But that patient, when he started to receive that furosemide, was already starting to eat. So it was a patient that was quite stable, but he needed some help from us. Common complications after surgery, to finish: hypernatremia. This is a pain, honestly, when it happens. And most of us are always bothered by the hypernatremia. A very easy way to recover or to make these patients to feel better is to take this solution, glucose 5%, and just go slow on it. Just put them on 0.5 to 1 ml per kilo per hour and watch how the sodium is correcting over the next 6 hours. If you go really, really fast, then you can have problems. We have not seen that much, honestly, although it's in the literature all over the place. But this is what we usually do to try to help with a hypernatremia. If you are a purist and you are going to do it just as the textbooks put in there, you have to calculate this form, or you put the values on this formula, and then you will see, or you will get a value on how much free water you have to add to that patient. In my experience, and has happened, I would say 90.9% of the times that I have used this formula, when you put this and then you give glucose 5%, it drops really quickly. So if, for example, I get a result of 100 milliliters, and the formula is telling me, okay, Luis, you have to give 100 milliliters of glucose 5% to this patient over the next 12 hours. And that means that my volume rate to that patient will be, let's say, 10 mils per hour of glucose 5. What I just do is just go half of the value that I got in the formula. You know what I mean? So I never go as high as it says on the formula, because most of the time it just drops too quickly. So this is another way that I found that it really works, and you can correct it quite easily. I was talking about acute kidney injury and synthetic colloids as one of the problems that we have. This is the only paper that talks about this in veterinary medicine. We'll see over the next years. We don't really know so far, but this paper is saying that the patients that got on this solution really had more trouble. So be cautious with this. And another problem that we have is metabolic acidosis and acute kidney injury. So that's why we are not using saline solution as much, and we are using more balanced crystalloid solutions as Ringer lactate, for example. Fluid overload and edema, again, and just to give this message really a stick on you, 10% of gain is enough. Try to match the ins and outs and give furosemide if the patient needs it. No, like this one that got a really bad edema on his conjunctiva because of the fluids. To end up, intra-abdominal pressure is something that happens on patients that got too many fluids, and it's something that we don't pay attention. And when this happens, I was talking about the fluid overload and edema on all of the guts. When this happens, what you have is a compression of the vena cava and a decreased preload. So your system will start to fall apart in different stages. But I will talk about more of this in the third lecture. The polyuria, as our patient had in this one, many times is due to a fluid excess, so it's just part of the recovery. But if your patient is not eating or drinking, sometimes it's a problem. So you really need to keep an eye on this and make sure that this didn't happen. When your creatinine goes up more than 0.3 milligrams per deciliter in 48 hours, that means that your kidneys suffer at some point during the emergency or after the surgery. So never disregard these patients thinking that the creatinine is still in normal value, so everything is fine. No, if this happened to you and the creatinine jump more than 0.3, be careful and keep monitoring this patient, because maybe we'll have some sort of problems. This was the first lecture. I'll be happy to take questions that might have not been answered during the lecture. So I'm yours for whatever question you might have. Thank you.
Loss or losses. You said about 10%, 25%, 35%. How do you get actual percentages?
The hydration.
The losses.
The losses on that patient. So if there are active losses, when I was putting that diagram on the slide, what it meant to the intravascular volume. So 10 to 25% of intravascular volume of losses, or 25 to 35%, or 35 to 50%. So that would mean the intravascular volume that patient has lost. So when we have the patient and we are trying to measure how much he has been losing through the day, there are not so many things that we can do. One is to weight him. So we try to weight him at least 3 times a day and see what has been happening with that animal. It's not very sensitive, but it can actually help you. I honestly prefer to try and measure if he has drains and a urinary catheter in place, how much fluid is in there. So if I can measure that, and then the patient has gastrointestinal losses, then what I do is a mix of all of them. I weigh the patient and I measure the urine, and I add the drain that it was there. If let's say the patient doesn't have drain or doesn't have any urine catheter, then what I do is just to weigh the patient 3 times a day. And with that weight, for the first 48 hours, I usually have enough. More than 48 hours is not very sensitive because the patient starts to lose a lot of muscle mass, and then you will get confused about the results. But that's pretty much how we do it, yeah.
What about the initial assessment of the losses, of the hemorrhagic losses?
Okay, in those cases, basically it's my physical exam and to know if the patient is compensated early or late, no? And because all of those 3 stages are based on physical exam parameters, the first one is more stable, the second one is less, and the third one is just about to die, then I try to put myself in one of those scenarios, no, and see, okay, I'm probably in the 25 to 35%, so I know if this patient has 80 ml per kilo of fluid volume in his system, 25% of that will be X, no, whatever it is. So what I try to do is to push with that calculation that I've made with the isotonic crystalloids and try to push up to that value and see how he responds. If I can avoid to get to the 100%, let's say that I got this patient needs a liter of fluids, I don't usually give straight a liter. I usually still go with a quarter of that, up to the liter that I calculated, because it's not 100% sensitive. So I made a mistake on that and give too much fluids to those ones. But to keep your life simple, just go with the 10 ml per kilo over 10 minutes and reassess the patient, because otherwise you will lose a bunch of time doing calculations. So that's something that maybe with practice you can do in another moment when you are more relaxed, no, or you have more time. But to be practical, just go with 10 to 20 ml per kilo, reassess. When you are up to 60 or 70 ml per kilo that you have given the fluid volume, you need to change your plan because that is not working. Yeah. Okay, so Blanquita. Blanquita was a 6-year-old female spay Shih Tzu who was bitten by a pit bull. He was really beat up by a pit bull. So he got thoracic bone punctures, fractured ribs, tension pneumothorax. And then we have Rantanplan, another dog who presented to us with this sort of respiration. Let's see if this wants to work. He came us as an emergency one day, and this was the way he was breathing, and this is what we found. He had a lung lock torsion, this dog, inside him. So either Rantanplan or Blanquita, no, both of these dogs at some point are going to need some sort of thoracic surgery, no? And the stabilization phase is really important, and the post-operative part is also really important. So we're going to face in here is what happens after thoracic surgery. What we know so far in vet medicine as the mortality is around 6%, and we know as the longest the surgery is, the more mortality they have. Some diseases like pyothorax or the sternotomy have a lot of complications. They can have a lot, but that doesn't translate necessarily into death of these patients. But there are no so many papers out there talking about what happens with these animals after surgery. And if you manage these guys, probably you have seen many complications happening to them. Some of them can be explained, some others we have no idea how to manage them and are quite complicated. So we'll try to go and give an idea on how to assess these patients, and you will see that basically it's all about the same all the time, no, the same tools, the same sort of methodic plan to assess these patients. And in these ones, if on the other one, on the other lecture, we were talking about the heart, the volemia, and the vascular. Here we will see that one of the problems that we some or many times have is how the lungs work. So how do I start with evaluation of these animals? Go back to the slide of the methodic plan on how to assess this patient. It works pretty much on every situation. But look on these ones, especially on the pulse oximetry, and take a look on how they are saturating after the surgery, because that can be the first thing that will make them die after the surgery, and it can be triggered for many things. So I made this lecture just trying to think when I get these patients just right into the ICU after the surgery, and how we move through these animals. If the first thing that I see is that SpO2 is under 94, then this is usually what I do. I usually start giving oxygen when I give myself time to assess the entire patient and try to look through all the possibilities that are making this patient to be wrong. No, check the probe reading is correct. This is something that we miss sometimes, but sometimes just the pulse ox is not working. And a trick that I'm bringing you here is based on this paper. And this is something that I was taught to always wet the gums or the tongue when the SpO2 is not, or the probe is not reading. But this paper actually told us something different. And it was just put a swab that is dry on the tongue of this patient and then put the probe on the tongue of the patient or on the lip of the patient, and it really works. So this is something that is easy, and maybe you can do tomorrow if you want in your clinic, or tonight, whatever you are being called to go to see an emergency. But it really works, and it's a trick that is really simple. Well, after that, check the patient is not open mouth breathing. Check for upper airway problem. Sometimes you will see, and you will have problems as we see. Do you have brachycephalic dogs here? I guess you see a lot of bulldog, French bulldogs, bullies, things like that. No, so it's a real problem in Spain. I mean, it's good for the business, but it's really bad for them. And we see many dogs who maybe the owner didn't even know that there was a laryngeal paralysis, and that's, well, something that happens. No, it's not the fault of anyone, but upper airway problem can be a problem after surgery, or if something was touched during the surgery or a dog like Blanquita got bitten in the neck, that can give you problems after the surgery. Many times they come with a chest tube in place, and this is something that it will make you or make life easier for you after a thoracic surgery, because if there is a chest tube in place, then you can suction and see the problem of hypoxemia is because there is air trap after the surgery, if there is too much fluid in there. If not, then use your ultrasound to take a look on what's happening in there. I think I have some slides on how to use it. The capnometry is another thing that you can use, and it's very simple. If you have a multiparametric monitor like this one, we use these nasal hoods or nasal prongs that we put on the patient, and directly we measure the CO2 on the monitor. So this gets attached like nasal prongs for oxygen, exactly the same for the CO2. There is always a gap between 10 and 15 millimeters of mercury, but can give you an idea if you don't have a blood gas machine or you cannot do a blood gas at that time on the patient. If you don't really know how to do a T-fast, I brought you some slides in here that can help you. This is quite simple. This is how we probably position the patient in there. And what you're going to see, when you are looking at the thorax, this would be the classical image that we see on these patients in this picture, and this dark side belongs to the intercostal space that is represented here. Here you would see, or it would represent the pleural line, and all of these lines that are just under are called A lines because they represent just the reverberation of the pleural line. So when you are looking at this and you have an image like this one, what you're gonna see is this, if it wants to work. Oh, vale. So on this video, what we are seeing is the intercostal space here, these A lines that are just the representation of the pleural space, and the pleural space is moving here, and this line that you can see here that is moving is the pleura that is sliding normally around the lungs. So this would be a normal image of a normal lung that is just working in a normal day and everything is fine. Okay, so intercostal space, pleural space with the glide sign that we call it when it's sliding the pleura, and the A lines that are just under it. So what happens when it's not normal, no? And when we put the probe on them and it's just not normal. Let's see if this wants to work. Yep. So when we have a patient with a pneumothorax, what you are going to watch is an image that is very similar to the last one, but here that is the pleural line and you don't see any sliding. So you can see the intercostal space, you can see fantastically the pleural space with the A lines that are the reverberation, but here nothing is sliding on this patient. Something that is very different to this image. That means that your lungs are really damaged. So this image is actually very different from the other one, in the sense that here you can see again intercostal space. Here is your pleura that is sliding, and in the middle you are able to see, or you are not able to see, the E lines that you watch on the previous slide, but you see this kind of shower, comets, rockets, whatever you want to call them. In English they call it different ways, but they are probably the most widely accepted are comets or rockets. And this, when you look at this, is just meaning that there is something in the lung parenchyma that is happening. So either is filled with fluids, with pneumonia, with hemorrhage, with whatever is in there, and can help you to know if that patient after surgery has a lung that is actually suffering or is not. No, you can also use the TFAS for other things. Maybe that dog or cat has a bunch of pleural effusion in here, or maybe has a pericardial tamponade like this one after surgery. So it can actually help you to have a better idea of what is happening on that dog and why he is hypoxemic at this time and what you have to do. I would say that maybe pleural effusion and pneumothorax are the two big ones, and of course some kind of pulmonary damage as well is a problem after a thoracic surgery. Okay, when you cannot get a good pulse ox reading, what you can do? You can try to get an arterial sample if you have one of the machines to look at the PaO2 and then calculate all of these parameters. So as long as your arterial pressure of oxygen is over 80, then you are fine, and then you have a better idea of what is happening. When you cannot do this, then you have to just rely on your pulse ox, and that's pretty much it. And most of the times what we do is just to give oxygen. If we cannot get an arterial sample and the pulse ox is not working, we just give oxygen for a few hours until we get the patient more stable. All these values, when you calculate them and you calculate the arterial alveolar gradient, are just telling you if the ventilation that these alveoli are getting is matching with the perfusion that they have. So when something is wrong and this gradient is higher than 20 milliliters of mercury, it's telling you that something is happening in here, and whatever the blood flow to the alveoli or whatever the ventilation to those alveoli is compromised and something is not working properly. If you don't have the possibility to use these machines, then all right, just move on with a pulse oximeter and try to get an idea on how he improves when you administer oxygen. If you have this machine and you have more questions for me later, I'm happy to talk about that. But since I have to move a little bit faster on this presentation, then I'll jump a little bit more on the management. Why can be my patient hypoxemic? All of these are the big ones. And I was saying pleural space disease is most of the times the big one, but don't forget that the pain can make you as well to be hypoxemic because you cannot ventilate very, very well. What should I do on these patients? Give oxygen to start with. What are the most effective methods to give oxygen? So we usually start with 1 cannula of oxygen, and we give up to 200 mils per kilo per minute of oxygen to these animals. If they don't get any better and I cannot get the SpO2 over 94%, then I place another cannula. So when I get into this situation that I have a patient with 2 cannulas and I still am not able to get the SpO2 where I want, what do I do on these animals? So I have 2 options. Either I choose one technique that I will show you now that is called high nasal flow oxygen, or I just go and put them on the mechanical ventilator. Those are just the only 2 options that you have. Why we go this way? With 2 cannulas, you already got a FiO2 over 60%. 60% is in the threshold to start to be toxic for the patient. And it's not that we are not going to go higher. We are obviously going to go higher with these therapies, but the patient is telling you that he cannot be any longer with this sort of treatment. So you have to do something different, right? And this is a patient that we use high nasal flow oxygen. This therapy is quite new in veterinary critical care. And what we do is to connect these special nasal cannulas or nasal prongs it goes connected to a machine that will provide high flow of oxygen. So if with a normal machine, with a classic concentrator of oxygen, we can get up to 5 liters, or maybe you will have in your clinic up to 10 liters, the most, no? In many clinics we can go higher, or we can go up to that value. With this machine you can go up to 40, 50, 100 liters, so you can go really, really high. So if we were using on this one 50 to 200 mils per kilo per minute, milliliters, with this system we can go with 0.5 to 1.5 liters per kilo per minute. And sometimes we can avoid the horrible thing to put patients on a mechanical ventilator, because when you put them in there, that's like a suction gumball machine. You don't know what's going to happen. Maybe we'll just suction the patient and it will die. So most of the times to put them on the mechanical ventilator is something that I try to avoid as much as I can, because the consequences can be really, really bad. Sorry. So this is a therapy to at least know that exists, that we are doing it, and it's something that is possible to be performed, and is not a big deal, although you can get patients with a pneumothorax when you are doing this. So it's a complication that we need to know. So what should we do with a patient that looks like this one? I have put this video many times on different presentations, and I have had different opinions. So just raise your hand. How many of you would intubate this patient and put him on mechanical ventilation? Only 1, 2? 1 or 2. Okay. I would put it as well, and that's what we ended doing. This kind of patient had 2 nasal cannulas. As you can see, the color is not good, and it's not a problem on the camera. But the other thing that you can see here, his eyes are just having a little bit of nystagmus. So that means that he's really hypoxic. And it's a video that I like to put, because even this dog, for the people that was at that moment, was kind of a problem on the management. After we put it on the ventilator and we started to back him with 100% oxygen, look at the SpO2, was 88%. So, and this was on 100% oxygen connected to a mechanical ventilator. So this dog probably, when we're recording that video, was at, I don't know, 70, something like really, really nuts, no, for him. So if you get in a situation like this, that you are doubting yourself and questioning yourself, should I intubate the dog or not? Just do it, because you are asking already your question. Should I intubate this patient? If you are asking you that, do it. I mean, it's not the end of the world. Just start again, and then start to investigate what is happening with this dog. No, provide 100% oxygen, plan chest X-rays. We'll see that after that. No, and see what is the problem. What if you have a little beast like this one? This dog was really funny because he was really cranky. It was a kind of dog that will bite you and kill you if he could. But look, like like he was breathing. So he was in deep trouble like this, and he was even trying to bite us like this. So he was doing what we call the fish mouth breathing. So he was just open mouth breathing, like, "Oh, I can breathe, but I'm gonna kill you." Oh. So he was just like that all the time. So when you have patients like this one had, I think it was a cervical hernia that he went to surgery. But when you have a situation like this, think about why hypoventilation can be happening on this patient. Is pain? Is drug related? Maybe he got too many opioids and we can help him a little bit. Did he have cervical or brain injury? Does he have a pleural space problem? And when you get used to see patients like this one, you already know that the CO2 is going to be high. But if you don't have that certainty that that's happening, just try to get a sample and see how is the CO2 on that patient. It doesn't need to be arterial. With a venous sample, if the patient is not shocky, you can have a very good correlation. And if the CO2 is that high, then probably he will need mechanical ventilation. That dog was lucky, and I'm pretty sure his demeanor and his temper helped him to survive because we never put him on the mechanical ventilator, although his CO2 was around 60 something, 62 or 63. So this dog really escaped to that situation. Here you have him again. So could be pain related. First, rule out other potential causes of hypoxemia. Check the chest drain. Take a look on how he's breathing. But if you have the suspicion that the patient could be painful because the last dose of morphine or methadone or whatever was given before surgery was a long time ago, then you have many options to manage these patients. Lidocaine, we know, is not a good option for cats, but we can go up with fentanyl, we can go up with ketamine. So we have other options. NSAIDs for this kind of patient is not something that I really like to do. Metacam or meloxicam or robenacoxib is something that I don't like in the immediate post-op until I see how they recover. But I would say after 24 hours, I think is a little bit safer. Now we are using others like dipyrone, for example, or paracetamol in dogs that really work well for pain management. So these are other options that you can use and don't actually go to the kidney to make damage. So these are all the options. And remember, these are the standard doses, but then every patient will be different. Maybe your cat, the one that you are watching, needs 8 micrograms of fentanyl instead of 6, no? And not necessarily 6, maybe he will be happy with just 1 microgram of fentanyl. Use this if you have it. Diffusion pain catheters is something that can help you to avoid the excess of opioids or ketamine or lidocaine on these animals and really work well in the post-op period. But just remember to place it after the surgery, okay? Because it can give you a relief of pain that is really helpful for the post-op on these animals. Once you get the patient under control, whether you decide to mechanically ventilate or just provide oxygen, then investigate the cause of this patient, no, and see what happened in there. If you need to do a BAL, do it. It's not the end of the world, but to start with chest rats. After the chest rats, you will have an idea of what is in there, and then you can make another plan for that animal, no. Pleural space complications, pneumothorax is the big one. Usually is a common complication that is iatrogenic because of lung laceration. When you have a pneumothorax and you cannot get negative suction, then is when we get into trouble, no? And when we have to decide what we do with a patient that just have pneumothorax and we are just trying to empty, but but we don't get that patient any better. So what are the options on those patients? The chest tube, it would be the first thing to use if you don't have it already in place. But when you cannot stop the pneumothorax, you have basically 2 options. Medical management, go back to the surgery room. No, that's basically the two options that you have. The medical management is something that we use, but no more than 3 days. And it goes with a system like this. This is continuous suction. This dog has a continuous pneumothorax because of a bulla that we could not control or find in surgery. So we place him on this system that is called Pleurovac. So it just gets continuous suction from the thorax of this patient. But this treatment should not be longer than 3 days. In 3 days, you are not getting any patient better with this. This dog needs to go to surgery. That's basically the summary. Pleurodesis is another technique that works well, but it works well usually when there is a traumatic event on the patient. If you have pneumonia or if you have cancer, for example, it will not work very much. And this is a technique. Are you familiar with this? Have you ever tried, any of you, this? This is something really cool, honestly, and it saves a lot of money and a lot of suffer to dogs and cats. So when you have a pneumothorax, for example, that is traumatic and you cannot control it, using the same blood from that patient and put it into the chest will help to heal and seal the pleura of that patient. So to put this on images, for example, I gathered some pictures of this dog that we did some months ago. So this dog had a continuous pneumothorax, and the technique is as simple as you see. So we just sedated the dog. I think this was just only sedated. So what we did was to take his own blood. So that's why the technique is called autologous blood patch. So we just take his own blood with no anticoagulants, with nothing. Just take his blood as it comes out from his jugular, and with a drain we just push it in there and let it sit for 4 hours at least. So once, or in the meantime that you are doing this and taking the blood and pushing inside, after the procedure you just roll the dog for a few times. After that we just stop or seal this for 4 hours and we don't drain the thorax and see what happens. It usually starts to seal after 6 to 10 hours. So you will see that your air production is going down through the maybe first 24, 48 hours. If after 2 days the pneumothorax is still as bad as it was before the pleurodesis, then your option is to do another pleurodesis or to go to surgery because it's not working for that patient. But it's something worth it to try because it doesn't take much blood of the patient. It's very simple and it works well in many of them. So if you get this horrible hit by cars, usually they get better when you cannot control the pneumothorax is doing this. Okay, so it's something to consider and technically simple. When you have these other complications like pleural effusion of these kinds, the hemothorax, the first thing is to try to get all these coagulation problems out of the table. Most of the time after a surgery of the thorax, the problem was the surgeon that just damaged a little bit the intercostal space and has some sort of bleeding in there. Things that you can do for those patients right away is to start this medication. Do you have the tranexamic acid? Amchafibrin, I think is the name. This is something now is really fashion and we use it all the time because it works on the fibrinolytic part of the coagulation that we have been forgetting for many years. So this is something that can actually help you. If the hemorrhage is uncontrollable or the patient is like this one that is accumulating tons of fluid in here and will need blood transfusion, then probably you will need to go to surgery again and see what happened. It's different if this patient is an emergency that comes with this inside. This probably will be cancer if it was not hit by a car. But if it goes after surgery with a bleeding like this, then he needs to go back to surgery if there are no problems with the coagulation on this dog. What do we do with pyothorax? There can be contamination during or after the surgery, and this is always related to the chest tube in place more than 4 days. There are other options for a pyothorax to explain it, like the hematogenous route, but on these cases, basically the management is simple. Do the same that you would do with another pyothorax. Put them on antibiotics, send a culture, wait for the result, and see how he's responding. If a pyothorax is not getting better in 4 days, then probably you will need to go to surgery as well and explore that animal. Chylothorax, another one that can happen after surgery. Not so often, but sometimes it happens. I have seen this especially in dogs, and it can be related to a cardiomyopathy that was missed during the diagnosis, or a little problem that the surgeon had with the thoracic duct during the surgery. Many times it resolves itself and doesn't need anything. But if the dog is not getting any better, then probably you will need to go to surgery if the production is as crazy as this one, over 10 meals per kilo per day. Okay. Otherwise, the management is the same one that you would do for another chylothorax. What else can I offer to patients who continue to produce fluid and the fluid is not either a hemothorax, a pyothorax, a chylothorax? Then a short course of steroids might help you if there is just inflammation that is related to that. Don't go crazy with the doses of steroids. 1 milligram per kilo per day is enough for that matter, for what we are looking for. Okay, we don't need 10 or 30 or anything like that. If there was a confirmation of neoplasia after the surgery because you took biopsies, then maybe you can do chemotherapy, and actually you can do a pleurodesis with chemotherapy. This is something that is being done with more or less success. In cats, I think there is a recent publication with not much success. We have been using it, the pleural chemotherapy, and 50-50. I would say that we have not been lucky in some cases, but in other ones have helped. When nothing works and that patient keeps accumulating fluid, there are always an option that is called the pleural port. And the pleural port is to place like a permanent drainage in the thorax that we can use from the outside. And it's like a little coin that is under the skin, and we can access that port and just attach a syringe and empty the fluid with the owner being at home. I mean, you can teach the owner to do this, and the owner can be at home with the dog and do this procedure for whatever that dog's needs or lives, no? But this is something that you can actually talk to the client. How much lung can be removed if we have a lung problem? So we have about 42% of capacity with the left lung and about 58% with the right side. So that's pretty much what you can do. About 56% of the lungs can be removed. That's a lot of lung, but the quality of life for this dog is not so bad, no? How we determine that there is a lung parenchymal complication? So through all of this process that we have been assessing that the dog is hypoxemic with an arterial sample or with an SpO2, and we have ruled out that there is no pain, that there is no pleural problem, and the chest X-ray shows that we have a parenchymal problem, then is when we know that probably we will need to do a BAL and to know what's happening in there. Your BAL can be as aggressive as you want. I usually just opt to go with the endoscope and get a sample. And sometimes if the animal is really tiny, we just do a BAL with a feeding tube and put like 5 to 10 mils of fluid and get as much as we can. And that's it, but gives you an idea if there are bacteria, if there is hemorrhage or what's happening in there. And then you need a good pathologist that take a look at the slide. One of the complications that can happen, and we don't think about it, is when we re-expand those lungs. If, let's say, for example, that dog had a pleural problem and now we re-expand those lungs, these lungs can get into real trouble up to 72 hours after surgery, because they have not been used to work in the new space that they have now, and they have been so constricted for a long time. So when this happens, there is no clear treatment. The prognosis doesn't need to be bad, honestly, but some of these dogs just die right after surgery if this is what happens. Sorry, because those alveoli are just getting re-expanded, and all the byproducts and inflammatory mediators that they have just get this massive pulmonary edema that is really difficult to manage. Aspiration pneumonia, like in this one that happened, Glass was a really nice dog who went to thoracic surgery, had as many complications as you can imagine. He had a little bit of all of the ones that we have been talking, but he finally made it. But this one ended with an aspiration pneumonia. And aspiration pneumonia, the key point is this: antibiotics yes, antibiotics no. And I think when we go to lectures and you listen and tell you don't give antibiotics are not needed, well, you have to take that into in the context of what happened exactly. So if the dog had an aspiration pneumonia event after a meal, then probably what is on those lungs is not nice, and probably will need antibiotics. So If that is what happened and I'm not able or I'm not willing to go for a BAL on that dog because he is not stable enough or I don't think it will go well, I just put them on antibiotics, honestly. And maybe this is not the most purest thing to do, but if there was food in there that got into the lungs, then my way to go is this one. If there was no food, there was nothing in there, then probably I will just stay without antibiotics on that dog and just hold myself on. And if I don't see the response that I'm looking for, then, or I have the dog already intubated, that scenario is different. If the dog got so sick that I need to intubate him, then I will get the BAL right away because I already have a tube in. So it's really easy to do it. Okay, so it's kind of a decision based on how the patient is looking like and how much you want to put on that animal at that time. But if there is food in there that you are pretty sure that it happened, just put him on some broad spectrum antibiotics. Amoxiclap will be good enough. Pulmonary hemorrhage. This is the dog with a septic abdomen that you saw on the first lecture, with the foreign body. So this is how she ended. So the BAL here honestly will help you quite a bit to determine that it was hemorrhage. Just check the coagulation profile. And these patients can only be managed by mechanical ventilation if they get to this point, and transfusions as much as they need. But there is not much more that you can do more than supportive treatment for them. Physiotherapy for this patient, respiratory physiotherapy, nobody knows the answer. Maybe it will help, maybe it will not. As much productive is the cough of those patients. Probably the physiotherapy and the humidification will help to mobilize even more the sputum that they have and will help to expel those particles that they are keeping. But nobody really knows how much impact this have on animals. The coupage that we are used to say, or the nebulization of drugs, maybe have another role on this, but this is something that I only use when the patient is coughing and is not getting the stuff out that we want to. For example, if this dog cannot go for a walk, and we know that walking the dog will really help the dog to get the sputum out, then probably with physiotherapy, with respiratory physiotherapy and nebulization, we will implement that dog. This poor dog is another disaster. This dog went for just a palate surgery and ended with a pneumothorax, ended with a pyothorax, ended with a tracheal laceration. So this was a mess, this poor dog. It was like 8 or 9 years old, Keke. He made it, but it took forever to make this dog to get better. What are the complications that you can see? Chest tube site infection, ipsilateral lameness from the site of the sternotomy. Sometimes they get really, really bad. Ventral edema, inflammation, infection of the site surgery as well can happen on these dogs. And then this one that we don't tend to think that much, but it happens. It's not very recognized in veterinary medicine, but we have seen many dogs dying from this, and in human medicine they know it happens, and it's thromboembolism. So what to do on these patients? Our way to go is usually to put them on heparin after surgery at these patients. We don't know exactly the impact of this, but the ones that we have been doing so far, we feel it goes better with heparin. We usually use the enoxaparin for these patients, and what we do is to put them just after the surgery, not before the surgery, and just follow up with the PT and the PTT, to know a little bit how it works. It's not, I would say, very specific on how the heparin is working, because you need to know the anti-10A levels to know exactly what's happening on these patients. But the ones that we have managed so far with this go a little bit better. Conclusions for this. I would say that with a general approach to these patients, you can sort out many things. The problem is when they get into trouble, you need a lot of resources for these patients. So you need to be prepared, if you are going to do these kind of surgeries, to have options for these animals, or at least to have the option to send the patient to another hospital if you don't have these options, and you had to do the surgery because it was an emergency surgery, but now the post-op needs to go somewhere else, no? Many times the treatment is aimed to be supportive, and you can really make things to get better on these patients, but it can take a little bit of time, no? And I think that's pretty much it. Well, it was not exactly on time, but I made my best. Sorry about that. Thank you very much. Any questions? Yep. I get, sorry? DIC. With thoracic surgeries? Oh, yeah. After dog attacks like this one, like the first one, yeah. Well, I would say that those are the tricky ones. I mean, if I am in DIC and what I've tried to make is an idea of what exactly is happening with DIC. I mean, I am in the hypercoagulable, I am in the hypocoagulable state of the DIC, no? For those cases, we have thromboelastography, and we are lucky that we have that, so we put together all the information that we have. How are the platelets? How is the PT, PTT? How is the thromboelastography on that dog? To put it simple, if I have PT, PTT that are prolonged, but I get a blood sample on that dog on the jugular, for example, and it's not bleeding, like a obvious bleeding, then on that dog probably I would put him on heparin, thinking that he is more on the hypercoagulable state. If he is bleeding, then I would just go with plasma on that patient, and as long as the liver is working, I would not probably put any vitamin K or anything like that. So I would just transfuse with plasma on that patient. If your question is moving to do I use plasma and heparin at the same time because we need antithrombin to make the heparin work on these ones, since we are no longer using the where we are moving more to the enoxaparin, and I have not been always a friend of mixing both treatments. On the one that is bleeding, the one that is bleeding, I usually don't use heparin. I just go with plasma, and once I get the times better and I see how the patient is responding, maybe I will consider myself to put him on something like works on the factor 10, something like the rivaroxaban, or maybe just go with enoxaparin, but I don't usually mix both of them. If has been attacked and I see that patient very inflamed, for example, let's say the leukocytosis is massive, there is a left shift, the fibrinogen is high, and then I have a PT and a PTT that are quite normal, then I would say yes, but not on the first 24 hours. Maybe I'll just wait to see how the patient moves over the first 36 and then decide, because I have done that many times thinking on let's be ahead of time. And I can show you many pictures of dogs bleeding like like crazy, from the nose, from the NG tube, from any puncture site. And the problem with the heparin that I found is that I cannot monitor very well the heparin because I'm using enoxaparin, so I need the factor anti-10A. When that happens, I'm using empiric doses of heparin. So what it worked on that study for greyhounds, that is the dose that we have now on the books, is what it worked for those greyhounds, but it might not be the same for that dog that I have in front. And I have realized of that doing animal after animal after animal and seeing how they bleed after I started with all of that. So I have backed up myself a little bit over the years because of that. So plasma if he's bleeding, if he's very inflamed and not bleeding, despite the coagulation profile or times, the PT and PTT, then I would say probably yes. Probably I will start. Steroids? Steroids will be talking in the next lecture, but the big summary of the steroids would be, do I have a pathology that justifies it? Do I have a dog that is hypotensive and refractory to everything that I'm doing? Then yes, I use it. But I never use, unless it's an Addisonian dog, I never use like a big shot of steroids when they come through. No, I try to teach people not to do that and just wait a little bit because you probably will need it. Okay.
Okay.
Something else. Yeah, sure.
Do you use both side drains or just one side?
Sorry.
When you try to drain the thorax, do you use one side drain or both sides?
Oh, that's a good question.
Because normally you use two so you can drain more. Don't you?
It depends. If the dog went to surgery, are we talking about that scenario? And I know from the surgeon what he did made with the mediastinum during the surgery, then probably I will just manage with one. But if I have a patient that I have no idea, I came from another place and is just being referred, and I see that draining just one side, I don't get anything from the other, then sure, I will go with two. Yeah. It's just what it makes sense at that time. No, if you are not getting what you can, then just place a second one. But if it's a pneumothorax that is just producing air and it was hit by a car, I found myself many times with just one chest drain that it works well. Okay. Happy to answer more questions if you want now. They want to go for breakfast or for the break, I'm fine. Okay, we'll see you when? It's break now? 15 minutes? Okay, thank you.